faculty members come together during their lunch hour to share with one another projects that they're working on and to dialogue and discuss methodologies, successes, and challenges they encounter in their work. This webinar series is intended to serve as inspiration and a networking opportunity for participants while recreating the collegial feel of the Lunch and Learn method. In this third session of the 2017-18 series, we will hear from Elizabeth Vanderkerkhoff and Joan Tranmer on the utilization of health administrative data to address nursing relevant questions from a health services research perspective. Dr. Elizabeth Vanderkerkhoff is Professor and Sally Smith Chair in Nursing in the School of Nursing at Queen's University. She holds a cross-appointment in the Department of Anesthesiology and Perioperative Medicine. Her primary research program is in the area of acute and chronic pain, as well as patient safety and healthcare quality. She was part of a team that developed one of the first electronic acute pain management systems in Canada, and she has leveraged this system to study the epidemiology of acute and chronic pain after surgery. Also joining us today is Dr. Joan Tranmer, who's a professor in the School of Nursing at Queen's University and the site director for the Institute of Clinical Evaluative Sciences Queen's site. She is also the scientific director for the Queen's Nursing and Health Research Program. As a health services researcher, she works with interdisciplinary teams in the conduct of research, primarily focused on systematic examination of patient, caregiver, and system outcomes of care for persons living with chronic cardiovascular and cardiac conditions, and on the development and testing of nurse-led delivery systems to enhance quality of care. A second research focus is on the understanding of factors that contribute to quality work environments for healthcare workers and the development of policy strategies to improve healthcare work environments, with a particular focus on female workers and their cardiovascular health. After Elizabeth and Joan's presentation, we will have time for questions. To submit a question for the presenters, please use the question and answer function, the Q&A function on your screens. Once you've finished typing your question, please don't forget to hit send. And I'll now, I guess at this time, turn the session over to Elizabeth and Joan so that we can all begin.
Okay. Can you hear me? It's Joan.
Yes.
Okay, great. Thanks, Linda. Liz and I are very thrilled to be able to present this session, and I think as Linda said, it's going to be, I hope, a good opportunity to have some discussion and engage in further dialogue about how we can increase capacity with respect to this particular research method of using health administrative data with health services research. So can I advance the slides? Sorry. Leah? I can. Good. Okay. So the seminar focus, Liz and I did discuss this, and so what we really wanted to do is really provide an overview of generally what healthcare administrative data is, but more importantly, share with you our program of research and how it's developed at the School of Nursing to really to better position nursing faculty and students in regard to using this type of approach to answer nursing relevant questions. So I'm going to do that part, and then we're going to share some examples with you, and Liz will talk about a series of projects that really focused on looking at patient and service outcomes. And then I will share with you a couple of projects where we've tried to really identify how we can link the nurse provider to outcomes. And then, as Linda said at the end, I hope we'll have a good discussion about not only the use of this type of data for research, but how we can increase our capacity in this regard. So please stop me throughout if you have, oh no, I guess you can't ask questions. So Linda did present Liz and I, so here we are. And I guess just to add a bit about why I'm particularly interested in this approach to research in nursing is that I do come from a clinical background of about 30 years in the hospital acute care setting in a number of roles, whether it was at the bedside or in management. And typically, one of the things we were always asked to do is, how do you know nursing is impacting care, or why are you doing it that way? So I was always had a very strong focus on trying to provide some objective measurement of the impact of nursing and to provide a strong argument for why I needed more staff or less staff or whatever. And secondly, during my PhD training, and Linda can probably attest to this, my supervisor would always say, well, so what? What impact does it have on what you're doing in the system? So that really did provide a very strong background for why I wanted to engage in this type of research. Liz can tell her story later. So I'm just going to go through a very high-level overview of what routinely collected healthcare data are, and because I'm not sure what the background or experience is of our participants in the webinar. So this is probably a review for many. So the data are generally routinely collected either through healthcare delivery, through monitoring of the disease, or other sources of care to the patient and the family at times. They are collected not for the purpose of research, but for the purpose of the organizational goals of the agency providing the service. And just in this day and age, there is just so much data out there. And I think while there is a richness of information, the ability to use that data in a way that is helpful for patients and families and nurses is a challenge. So these are just some examples of where the sources of routine collected healthcare data come from. They come from disease registries that can come from research studies or chart reviews, or for example, the stroke network or the cardiovascular network in Ontario provide data with respect to diseases. There is use of routine administrative data, for example, through the hospitals or through physicians through their OHIP billing. We can get clinical management data from records or databases. There's surveillance data through registry, the public health system, and as I said, there are many other sources of data that are becoming available for use. So some of the strengths of using healthcare data is that it's population-based. So you have a good understanding of what's going on within your population of interest, and so there's less risk of bias. There is the ability to use objective measures as long as you know what you want to measure. It can be cost effective. You have the ability to have a large sample size without following patients for a long period of time. We can get information about healthcare costs and utilization. You can combine it with other sources of data. So for example, you can combine a disease registry data with demographic data and have a more complete understanding of the patient. There are limitations because the data is collected for purpose other than your research question or the research you're particularly interested in. There will be missing information. So, and this is a particular challenge for nursing, which I'll talk about later. There is some lack of quality control. So if you're basing a diagnosis based on what's been abstracted from the medical record, your diagnosis or that coding is only as good as the data that's been abstracted. But there are measures in place to assess the quality in many of the databases. One of the challenges is that there are changes across time with respect to how the data are collected. So you have to watch for that. As well, and this is particularly across Canada, the way different provinces or institutions or programs report a particular diagnosis or an event or a procedure can vary. So that's a challenge too. With respect to nursing, our largest challenge, at least in my perception, is that the ability to use the data for nursing relevant questions. We don't collect good data related to function and symptoms, etc. So we'll talk a bit about that later on. Okay, so that was just a bit of background about data. So now I'm going to switch gears and talk a bit about what we do here at Queen's. So the Queen's Nursing and Health Research Program has evolved over a number of years. And recently, in the past 5 years, we sort of regrouped and identified 3 clusters of care, one being research related to populations with complex conditions, one related to healthcare quality, and one related to practice environments. And within each of these clusters, there is a number of faculty with shared research interests and research projects. And we do acknowledge that they do overlap, but we were trying to create groups where we could have some discussion and have some common meetings in regard to moving research forward within Queen's. And the other rationale for developing this program was to really help our new faculty build their own research programs. What we also decided when we were identifying the common clusters, that we wanted to build some research methods expertise. So we had the beginning program related to knowledge synthesis. So there were a few faculty, including Liz and myself, that had brought some expertise with respect to use of the routinely collected healthcare data. So that we identified that as a research platform that we wanted to build to allow for the work within each research cluster to take place. So we targeted that as a research program building initiative. So we focused on working with the Institute of Clinical Evaluative Sciences here at Queen's. We have a satellite site. For those who aren't familiar with ISIS, it is a large organization that holds a number of extensive data holdings. There are 7 sites across the province, and so we focused on working with our site here at Queen's. Liz was an ISIS scientist, and I became an ISIS scientist a few years ago. So that allowed us to provide mentorship and research support to faculty and help to build our own programs of research too. Liz was appointed the Sally Smith Chair in Nursing, and in that chair position she had a responsibility to mentor new faculty. So not only did the chair help, but the expertise that Liz brought to to the chair help move the program forward. Recently, I was appointed the site director for ISIS Queens, and this has been important not only for me but for the program, because it allowed me to have a better understanding of all that ISIS Central, or ISIS as a whole, can offer, and the ability, for example, to understand what data sharing agreements are. We're working, for example, with the College of Nurses to try and bring their data into ISIS. So I think having nursing presence within these bodies is really important. One of the most important things we did is that we worked with our director here at the School of Nursing and requested funding support for an analyst position. And what this allowed us to do is that we had 0.5 of an FTE position that really was present and knew the nursing projects, and that allowed us to go back and forth with someone with expertise within the ISIS. And this was really important because the process within ISIS, it's not that it's cumbersome, but it is detailed. And so the analyst helps the new faculty work through that. The expectations are that the faculty who have identified themselves as ISIS faculty, that they apply for funding and that position becomes cost recoverable. The other thing, other strategy we used was that we have regular ISIS meetings. We call them ISIS meetings, and to really talk about the research approach, what data you want to use, et cetera, et cetera. So they're really important. Just recently, we're starting to get graduate students involved in projects. There is a process that through ISIS that you can get student training and student support, and so I now have one PhD and one MSc student involved in an ISIS project. Just this year, we collaborated with the Public Health Sciences Department here, and we've launched a new health administrative data course that our students can take as an elective for their PhD or MSc. And this, again, really provides some key background information to using data for health services research. And we continue to look at opportunities to expand our collaborations and network. So this process really took place over I would say, the course of 4 or 5 years, probably 5 years. So it doesn't happen overnight, but we have been successful. So this is something I reported on, I guess, just this November. So within the whole Faculty of Health Sciences, 11% of the projects within ISIS Queens are led by nurses. So that's quite impressive from my point of view. So it just shows that with some commitment and support, we can make this happen. So Liz, I'm going to turn it over to you.
Hello, everyone. Thank you again for being here today and for allowing us to present some of the work we've been doing over the last 5 or 6 years, as Joan stated. I'm going to review a few examples based on the data that's held in ISIS. And I'm going to start, though, by talking just briefly about funding. And we've been fairly successful in getting funding for our projects from what's called the Applied Health Research Questions Program. And there are three types of questions that you can ask or get funding for within this program. But in all cases, there needs to be a knowledge user that really is driving the need for the question. So the first type of question is a rapid response. So if you wanted something, if the knowledge user wanted a quick answer to something for a first blush, that usually takes place within a week, so it's very short turnaround time. The second one is a research report or technical brief, and this would generally be a synopsis of existing research evidence. And then the third one, which is the one that we've been successful in getting funding for our projects, is called a research project. And so this is where new knowledge is necessary. So new primary, either primary data collection, or in our case, we use administrative data collection, and we conduct a whole new project to answer these questions. So the first set of projects I'd like to talk to you about utilize the HOBIC data, and most of you are probably familiar with the HOBIC data, but we wanted to look at exploration of quality of care outcomes based on the Health Outcomes for Better Information and Care database, which is the HOBIC database. The investigators on the project, aside from myself, were Dr. Kevin Wu, Rosemary Wilson, Kim Sears, and Joan Almost, and they each led one of these projects, and we worked together as a group, and this was part of building the capacity within the School of Nursing, right? I led this. They were at the time relatively junior faculty members, and were new to using administrative data for research studies, and so this was part of that process. And our knowledge user for this was West Park Healthcare Centre in Toronto. So I'll give you, in the next slide or two, I'm going to just go over some of the basic examples of the data, and this is a very high-level overview of these studies. I'm happy to answer any questions later, or if you want to get in touch with me if you would like some more detail, especially on the projects that aren't published yet, feel free to get in touch with me. We have our email address at the end of the presentation. But some of the examples of the data in HOBIC, there's some symptoms data, so pain, fatigue, dyspnea, nausea, falls, pressure ulcer. There are also some questions around medication knowledge. As well, activities of daily living, and you can see some of them listed here. And as I said, there is other data within this database as well. But for the purpose of our 4 projects, we focus on some of the symptom data primarily. So the first study I want to tell you a little bit about looked at pressure ulcers and related skin problems across sectors of care. Kevin Wu was the PI in this project, and it's published in the International Wound Journal, so you can go there for more details about the study. But just to give you an overview of what we found in terms of prevalence, we found that between 2010 and 2013, which was the time period of the data we used, there were about 700,000 patients in that cohort, and what we found is listed here. And the 4 sectors are acute care, home care, long-term care, and complex continuing care. So the highest prevalence of pressure ulcer was found in complex continuing care, and you can see that's the purple line at the top, and the range there is 20 to 25% of patients had pressure ulcer at the time that data was collected, followed by acute care, where the range was around 10%. Long-term care was around 9%, and then home care, it was lowest in home care, however, just at or below 5% over those 4 years. A lot more information about this in our study, and we're actually still working on pressure ulcer with other data, but for now you can see what we were able to do with the HOBIC data. The second project within this group of projects was looking at pain and related symptoms across sectors of care, and the PI for that project was Dr. Rosemary Wilson. And here you see, again, a brief synopsis of what we found. So across the 4 sectors of care, the blue line represents mild pain, red is moderate pain, green is severe pain. So you can see, again, complex continuing care, you see high levels of moderate to severe pain. Approximately 50% of patients reported that. And there were about 17,000 patients in that cohort from complex continuing care. Similarly, the rate is around 50% in home care. So home care, if you note, it was the lowest in terms of pressure ulcers, but they have one of the highest rates of moderate to severe pain. And there were about 16,000 patients in that cohort. In long-term care, patients are also reporting high levels of mild to severe pain. Again, and there were 160,000 patients in that cohort. And then with acute care, you see the lowest proportion of patients reporting pain within acute care. There were over 500,000 patients in the acute care cohort. And then the third study that I want to talk to you about is looking at safe medication delivery in home care. And this study was led by Dr. Kim Sears, and it's published in the Journal for Healthcare Quality. This is just one of the figures out of that table. I wanted to just draw your attention to some of the information we were able to capture. And what we're looking at in this figure is the percentage of individuals who had little or no medication knowledge, stratified by the number of medications they were taking. So if you look up to the far right of the figure, you see the legend. So the number of medications range from 0 to 5 up to over 21. So when you look at what's happening in those first two questions, the patients reported they do not know what to take and do not understand the purpose of what they're taking. You can see a very clear increase in the percent of patients reporting that they don't know what they're taking or why as number of medications increased. When you look at whether they were able to take their medications or not, you can see the percent reporting that they were unable to take them is lower. It ranges around 5%, and that didn't vary across by number of medications they were taking. And again, loads more in that article if you're interested in looking at that. Then the fourth project, which is still in progress, we're just writing this one up, and this one specifically looked at the sensitivity of HOBIC, so looking at the sensitivity to change in long-term care. And what we found so far, we're still working at this, looking at this, and we need to, of course, there's a lot of information around some of the points I'm going to tell you right now. So you need to think about that when you look at these results. But what we did find was that HOBIC was able to detect change in activities of daily living during the first year in long-term care. And what we found generally was that mobility and self-care ability decreased, but that symptoms remained unchanged, so the reporting of symptoms, except for pain, which actually improved over the course of the first year. And when you looked at individuals who were either had acute care admissions or ER admissions during that first year, you saw fairly pronounced differences between that group and the individuals who were not admitted. So in terms of summary and conclusions of the overall HOBIC project, so there's growing emphasis on optimizing safety and reducing risk within the healthcare system, and analysis of aggregate data may actually be able to help us identify care gaps, and I think that's fairly clear from what we found in our studies. And so we can identify vulnerable populations for resource allocation. There are some questions around validity and generalizability of administrative data, and HOBIC is also, these issues are there with respect to HOBIC, and I'm not going to go into that right now. There's been a lot written about that. Linda can certainly speak to that better than I can. But again, when you're using administrative data, it's really important to look at the limitations of that data. And one of the questions we also thought of as we're going through this process, is it important or feasible to collect patient-reported outcomes for admin purposes and research purposes? There were some issues around data collection and even getting sites, to participate in the data collection, and it adds burden to the healthcare provider. So there are issues around feasibility that need to be addressed, and maybe there are better ways to collect this information. So there are two other studies that I'm going to review briefly, and these look at different types of data held by ISIS, and the outcomes for both of these studies, health service use after surgery, and the two study The two examples are ambulatory surgery and lower limb amputation. The types of data that we use for these two studies are listed here. So for emergency use, we use NACRS data, National Ambulatory Care Reporting System, is I believe what that stands for. For admissions, we use the CAIHI discharge abstract data. For ambulatory surgery, we use the same-day surgery database. And then there's some other databases listed here. Some of them are necessary to use for all ISIS projects, just in terms of identifying patients, and others like the census data, where to get at some of the demographics. So the first study I'd like to talk about is the incidence of emergency room visits and hospital readmissions following ambulatory surgery in Ontario. Dr. Monosani was the lead on this one, and again, this is a similar situation where I was the ISIS scientist and also the working with some of the more junior faculty to increase capacity and using administrative data in the School of Nursing and in Queens in general. The knowledge user for this particular study was Brockville General Hospital, and they came to us wanting to know about emergency use and hospital admissions after ambulatory surgery. So we looked at the first 3 days after ambulatory surgery. And what we found, first of all, the demographics of this cohort that we examined, there were over 1 million adults over the age of 18. Mean age was 55. Just over half were female, and 85% lived in urban residence. We're actually in the process of analyzing doing the same sort of analysis, but on children. So in terms of the adults, a brief summary of what we found regarding the outcome is that 4.5% of patients sought healthcare use, so acute care healthcare use within 3 days of ambulatory surgery. 2.5% came back to the emergency room, and 2% were admitted to hospital after the surgery. I didn't go into all the surgical procedures, but this was the list of most common surgical procedures that CAIHI produced. There were about 12 types of surgery. The rates that we found are similar to what has been reported in the U.S., which is between 3.1% and 5%. As far as we're aware, this is the first study that's been conducted in Canada. And the primary reason for returning to ED and was for bleeding and acute pain. For admission, the primary reason was something called convalescence after surgery. This is where using administrative data is kind of tricky. Something like 40% of patients were admitted for convalescence following surgery. And so this, I think, after going back to the hospital and speaking to some of the clinicians, we believe this is a term that if a patient can't be discharged after ambulatory surgery, which many of you may be familiar with, they're just not, whether they're not waking up or they're sick or there's too much pain, they're sometimes coded as that. So that was the vast majority of patients who were admitted. The second study is looking at, and this group was looking at healthcare utilization after lower limb amputation in diabetics. And specifically, we were interested in looking at the comparison between patients who were discharged to rehab versus home. And the rationale for this was the knowledge user was West Park Healthcare Center in Toronto, so they were interested in this information. The lead on this one was Kevin Wu. And again, we looked at the number of ER visits and hospitalizations for all causes, but in this case it was 1 year and 5 years after surgery. And like I said, the comparison group was looking at rehab versus home care. And the results I'm about to show you on the next slide were controlled for confounders like age and comorbidity. Excuse me. So what we found, of them, there were just over 4,000 patients within this cohort. About 27% of them had through or above knee surgery. 61% were discharged to rehab and 39% home. And most of them had some home care attached to that. 10% of patients of the full cohort, 10% made over 48 visits to the eMERGE in the first year after surgery. And admission to rehab compared to home, patients had a slightly reduced risk of admission to ER in the first year, but they had a 16% increased risk of admission to hospital in the first year for the rehab versus the home group. Again, there's lots happening, lots more in that study. And what I forgot to mention with Mona's study in ambulatory surgery, that paper for adults is currently under review with CNHA. And this paper here that I'm working on with Kevin Wu will probably be submitted by the end of the month, hopefully. I'm not sure which journal we're going to yet. And that's it for me. I'm going to pass it back over to Joan.
Okay, thanks, Liz. So what I'm going to share in the next two projects is that during the process of doing this, one of the major limitations is that the ability to identify nursing within the database or non-physician providers. So I'm going to share with you two projects where we've addressed that in some way. So the first study was a project where we wanted to look at the nurse practitioner prescribing pattern in Ontario from 2000 to 2010. And the second one is a study that involved a PhD student where we actually linked some organizational survey data done in primary care setting to electronic medical record data. So we were able to identify the nursing model or the number of nurses there and link it to what patient outcomes in the EMR data. And if you want more detail about these studies as I quickly go through them, they are published in the papers that are listed on the slide. So in the NP study, what we were able to do through the ISIS data, we could identify all the nurse practitioners that were in what's called the corporate provider database. But because they don't bill through OHIP, we couldn't identify the patients that they were linked with. However, nurse practitioners do have a prescribing number. So what we were able to do is identify all Ontario residents who were over the age of 65 who were dispensed a medication that was in the Ontario Drug Benefit Database, and that was linked with the identifying number of the nurse practitioners. So we went about identifying the nurse practitioners and the patients they cared for in almost a backwards way. And then we looked, this was a descriptive study, so we wanted to understand where the NPs were providing care. We wanted to know what the distribution was and what the change was across time. We did compare practice with physicians during the same time period, and we used a number of databases. So I'm just going to share some key findings with you. So from 2000 and 2010, you can see that certainly the number of NPs practicing has increased. And particularly after 2005, 2006, where we introduced family health teams and the primary health care reform strategies. And in the third column is the number of NPs who dispense the medication to a person over 65 years. So again, you can see that the introduction of NPs in Ontario has certainly resulted in an increased number of NPs providing care. So one of the things we did, and I'm just showing one map, is that we looked at the change from 2000 and 2010 and looked at the number of nurse practitioners per 10,000 population in Ontario. So what this map shows is that there's a greater proportion of NPs practicing in the north, in the south and east part of the province. It's somewhat less in central Toronto area, and around Hamilton is even less. So this, the 2000 map was similar, but the proportion density increased to 2010. One of our analysis looked at the medications and the types of medications that both the NPs and the GP or family physician provided. In 2000, most of the medications prescribed by nurse practitioners were for acute conditions. And as you can see, up into 2010, that the prescribing practice was very similar between nurse practitioners and family physicians. In fact, the only difference was that the nurse practitioners in 2010, and it's not the case now, they were not able to provide controlled medications. So, what we were able to determine is that the implementation of NPs, that the ability of NPs to prescribe to older adults has increased. The prescribing patterns have changed across the 10 years. That's becoming similar to physicians. We are currently doing a project where we're using the same methodology, but we're going to look at the patient profiles across time to see if the patients cared for by NPs changes across time. One of the analysis we did, we looked at the variation across our local health integration networks with respect to the number and proportion of NPs prescribing in response to the number of older individuals in the LIN, and there was a large amount of variation. So that was that study. So the second study with respect to primary care nursing is that similar to what we did in the acute care setting many years ago when we were trying to understand staff mix and the staff density, et cetera, on the delivery of care, what we are trying to do in this is try to determine the relationship between different primary care delivery models that incorporate nurses and health outcomes in patients with type 2 diabetes. What we did is that we did a data linkage study. There was an organizational survey that was completed by primary care practice sites that were part of our LIN here, and they were linked with patient-level data that was housed in the Canadian Primary Care Sentinel Surveillance Network, which is also has the lead site here. So this sits and collects electronic medical record data for the purpose of surveillance. So we were able to work with 8 family health teams, and that each family health, between those 8 family health teams, there were 15 practice locations. And as I said, this was part of a PhD dissertation project, and the student learned a lot. So across the 15 practice sites, what this table just shows you is the number of GPs in that particular site, the number of RNs, the number of patients with diabetes, and the patient characteristics. So you can see across sites there are different numbers of patients and RNs, so there was variation. We had a total number of over 6,600 patients with diabetes. So one of our analyses is that we looked at the different indicators that we collect from the data about diabetic outcomes. For example, their hemoglobin A1C, their fasting blood glucose, blood pressure, their low density cholesterol, and their creatinine ratio. What we did is that we looked at the number of diabetic patients per registered nurse across the sample and broke that down by quartile. So if a nurse was taking If there was one nurse in the practice and less than 90 patients, that practice was identified as quartile 1. If there was the number of patients was greater than 311 per nurse, then that was identified as quartile 4. So what this analysis showed us that for certain indicators, there was a relationship between the patients per registered nurse and some of our diabetic outcome indicators. So if there were less patients per registered nurse, then, for example, you're more likely to have a better hemoglobin A1C and fasting blood glucose. This analysis we controlled for site characteristics. So I know we've just provided a very, and I see it's 10 to 1. These are just examples, and as Liz said, if we're happy to provide more detailed and more information about the studies. So I open the floor up.
Thank you, Elizabeth and Joan. If anyone has any questions they would like to submit, they could type them into the Q&A chat box now. We have a question from Elsie. How did you find the level of difficulty obtaining the data from CAI?
It's Joan. So I can answer that. So within ISIS, they hold the CAI data holding. So that was a rationale for working with the ISIS data holdings. So we access the CAI data through ISIS. I know you can access it outside of ISIS, and my understanding is it's a fairly straightforward process. I don't know, Linda or Lizzie, if you've done that.
Is ISIS an Ontario-based organization?
Yes, it is. But there are similar units across Canada. So, for example, I'm going to forget the names. In Manitoba, Health Services Research Utilization, and in BC it's something else. But there are similar units across Canada.
Elsie commented that her current experience has been really difficult to obtain data from CAI. Does anyone else have any questions they would like to ask at this time? Sally asked if your study methodologies included some of the new data science methods.
It's Liz here. I'm not entirely sure what you're referring to with respect to the new data science methods, but what I can say is with the ISIS support and the funding that we get from ISIS, that funding is primarily used for an ISIS analyst, and these are highly trained individuals with backgrounds in biostatistics and epidemiology. And so when we're conducting the studies and determining the analysis, they have a lot of input, and there are some senior analysts available for them if they have questions. So in terms of the analysis, I would say we're using some of the latest methods, but I'm not entirely sure if that's what you're asking.
So some examples that she gave were natural language processing or artificial intelligence, machine learning.
Yeah, that's an interesting question. Certainly, the analysis we do not use that, but there is certainly talk about incorporating those type of methodologies and linking them within ISIS. I know that.
Just give another minute to see if there's any further questions. Okay, I don't see any coming in, so thank you again, Elizabeth and Joan, for presenting, and Linda for being here as well, and thank you all who participated today. The recording of this session will be made available on CASN's YouTube channel in the coming days, so please feel free to share this link with your networks. And CASN hopes you will consider attending the next session, which is on Thursday, February 15th, and you can find out more information about that on our website at CASN.